Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we bring practical, peer-to-peer insights to help you deliver high-quality, patient-centered care. I'm your host, Amanda Mixon, and today we're going to dive into an important but often misunderstood concept in lupus management, treat to target, and specifically how DORIS Remission fits into real-world clinical practice. Joining me today is Heather Finlayson, who I'm sure many of you recognize as a previous RhAPPcast guest or through her great work with RhAPP. Heather brings a wealth of clinical experience and practical perspective that really resonates with the way we practice. Hi, Heather. Do you want to introduce yourself?
Sure. Thanks again. Hi, Amanda. So I'm Heather Finlayson. I'm a PA in Littleton, Colorado. I am a practice called Summer Rheumatology. I've been in rheumatology for almost 14 years, so enjoying every minute.
Awesome. Well, again, thank you so much. And I'm really excited to talk to you about this particular episode because we're going to talk about treat to target and focus on what this actually looks like in the clinic. What does success in lupus really mean? How do we think about remission in a way that's actionable? And how can we align our treatment decisions with meaningful goals like DORIS remission, reduced steroid burden, which we're obviously always trying to do, and what this really looks like in day-to-day practice? If you've ever felt concepts like DORIS remission sound more theoretical than practical, this conversation is definitely for you. I know I have. So with that, let's go ahead and get right into it. So Heather, when you think about treat to target goals in lupus, what does success actually look like in practice?
Yeah, so I think, it's kind of a newer concept I think that we're thinking about in lupus because we think about this sometimes in some of our other diseases, but really trying to get to the root of their issue and trying to get them to a clinical remission where they're not having symptoms, flaring, increasing steroids, all those types of things.
I totally agree. I mean, it's so interesting to talk about remission and low disease activity in lupus patients. I mean, we've been talking about that in rheumatoid arthritis for many, many years, but it's kind of a newer concept when we think about lupus patients, probably because we didn't have that many therapies. And so, now we are in this era, I think, of actually talking to our patients about remission. So let's really get into why treat to target matters in lupus. So, based on what you mentioned earlier, would you define that as a treat to target approach? And how does having a defined treatment goal change care compared to a more reactive, flare based strategy?
Yeah, I think as we learn more and more about how steroids are not great and those types of things, we would use that more reactively. I think this treat to target is being maybe a little more aggressive with how we're treating these patients so that they're not having those problems down the road. And I think that's something that's kind of new, maybe in the kind of lupus where we're thinking about that more. But we want them to be on stable maintenance therapy and not flaring. And I think that's kind of where I think about that treat to target.
Yeah, me too. I mean, I think, patients, when they're diagnosed with lupus, it's so scary, right? They can go down the rabbit hole and they can, look and say, oh my gosh, I'm going to need a kidney transplant. I'm going to die from this disease. And, really when I talk to people, I'm like, listen, this is not the days of, the 90s and the early 2000s when unfortunately, we didn't have a lot of therapies. And now we really can look at you, get you into remission and have you live a relatively normal life. I mean, of course, that means coming into appointments and taking your medicines and getting labs frequently and all of those things. But I think really having that goal, and I totally agree with you, when we talk about, not being reactive, as in, like tons of steroids or being more aggressive up front. I think that that's really, really smart. And I think that that's what we need to be doing with our patients. On that note, from a patient perspective, what is the real benefit of aiming for a defined, treatment target versus settling for what, we might feel like good enough control is?
I think when patients want to feel better, right? They want to feel like they don't necessarily have a disease every day of their life. They want to live like normal life as much as they can. And I think we now kind of have that ability to do that and data behind it and guidelines behind it. And I think really trying to, get into their like we don't good enough isn't good enough anymore, right? We have the ability to do better. And so again, every patient looks so different, but I think putting that into their minds that we can do this, like we can continue to not just settle for mediocre. We can try and get patients feeling better so they can live their as much of a normal life as possible.
I love that you brought up the guidelines because I think it's been really helpful to me, thinking, and knowing that we have these new ACR guidelines, newish, I guess now, and and actually being able to utilize those strategies and put them into clinical practice. So, how does having a clear treatment target influence your decision making in practice?
So I think, not having done a lot of research in my career or anything like that, I didn't necessarily do a great job of having certain, scoring ways of like making sure I'm monitoring for disease. And I think now, like with the SLEED I2K and having very like more objective ways to really measure disease activity is really helpful for me because it can be so ambiguous, right? Because one person's flare looks different from another person's flare. Like, what does a flare mean? Maybe, it may clinically be different for patients, but what does it mean in their blood work? Or what does it mean if they need to go back up on steroids? And so for me, just having that more, kind of way to look at what remission means by a clear guideline is really helpful when it's this kind of ambiguous patients are so different, right? I think that's where I find the benefit.
Do you feel like it helps you recognize when it's time to like escalate therapy or bring more structure of steroid tapering, or even change how you're talking with patients about their progress?
Yeah, I definitely think, we can measure a lot more minute changes when we're using a measurement tool because, again, it's detects little things that maybe the patient doesn't feel, right? And I think that's the key too is like there's stuff going on under the surface that patients may not necessarily feel, like damage to the kidneys, right? So if we have an objective measure that we're looking for those things and we can detect when things are going the wrong direction, we can talk about, how that affects their organs and why we would want to potentially, work on getting those steroids down or have to go up and those types of things.
Based on your understanding of the ACR guidelines, how does DORIS remission help reinforce treat to target as a meaningful goal in lupus care?
I think it allows us to be, again, more aggressive up front. So we're not being so reactive and being able to use biologics early. And, again, in my clinical practice, I've used biologics early in lupus patients. And, again, I can't say that this is definitive, but like, they sometimes don't have some of the organ damage issues that maybe they would if they didn't go on biologics earlier. And I think just thinking about how we can control their disease versus just being reactive with flaring, I think is important.
I think this is so far such an amazing discussion on why treat to target matters. But let's get in a little bit more to specifically talking about steroid minimization as a central part of the goal. Obviously, this is a very important aspect when we're talking about our lupus patients. So, why is steroid minimization such an important part of the treat to target thinking in lupus?
Well, I think, we love steroids and we hate steroids, right? So steroids work quickly, but then we know just the longer the patients are on steroids, the more comorbidity they're having, like the more issues with their bones or organ damage can be an issue. And so I think that's been such a focus I've heard kind of through the rheumatology community, especially over the last few years, of just really minimizing steroids as much as possible and using more they're needed. But then as soon as we get patients controlled, try to get them back down again. So I think it's we know this DORIS remission gives us that goal of trying to get down to 5 milligrams or less.
It was interesting. I remember doing this podcast and it really stuck with me because I was talking to Claudia, who's a nurse practitioner in Michigan, and she called steroids the devil's candy. And I actually
Yeah.
when I talk to patients, like I literally that's what I say to them because I'm like, it's so true. They work
Mhm.
great, but they are not, not good long term. So how do
Yeah.
you talk to your patients about steroid goals?
So, I mean, I think, goal is always no steroids, right? If we can, but I think we do, want to try to get them at least to 5 milligrams or less. And I taper slowly, right? I think I'm not going to just take their steroids away. I mean, I've talked to many patients that like, oh, they just stopped my steroids or I went down so quickly that they, flared again and then they're having to go back up again. So I think for me, slow and steady is a good way to start tapering when we can, because again, we can find those kind of nuanced changes of where they may feel okay and where they don't. And also just I think they buy into it a little bit more when we're not just cutting it down so aggressively that they start flaring again, right? Or they don't feel good.
So, how do you balance the reality that steroids work quickly with the need to reduce long term burden?
I mean, I think it is something that you have to have that conversation with patients because they like steroids in a lot of ways, right? A lot of patients are like, I feel better on them. But I think as we've gotten more data in just kind of the end organ damage that can happen, the morbidity that can happen, mortality sometimes that can be associated with steroid use, and the fact that we have medications that can help us get patients down and off of them, that's why I think they buy into that when they can still feel good and go down on their steroids. So I think that's just a good conversation to know that steroids are great, but then they're really only there for a bridging therapy.
Absolutely, and I totally agree with you, and I think we have to think about that as, what are we and, what I say to patients is, "I'm thinking about you today, and obviously nothing works as well as steroids do, and sometimes we really do need even high doses to manage their disease effectively, and efficiently. However, where are you right now, but where are you gonna be in 20 years if I still have you on 20 milligrams of prednisone? I mean, not to mention that you're gonna be breaking bones, you're gonna have
Yeah.
diabetes, cataracts, probably cardiovascular disease. I mean, so it's like when we talk to our patients, I think we really have to set the stage that yes, we need them. They're amazing. They are lifesavers, but long term, you will suffer if we keep you on this. And that's going to get me
Right.
to my next question for you, which is what should APPs be asking themselves when a patient remains dependent on those higher steroid doses? We all have them. So, what
Yeah.
what should we be asking ourselves?
So I do think, we always are questioning, what am I doing with our maintenance medication that's not maybe optimal because they're still on steroids. And I think some of it also, we just have to kind of, again, I think that's where it comes into tapering slowly because again, if I'm saying I'm going to take you from 20 to 5 in 3 weeks, like they're going to freak out, right? But if I could, go down a little bit slower, and granted, yes, it's a longer taper, but again, if they're not feeling that really big jump that makes them feel bad again, they're going to be buy into just really, us trying to control their disease with less steroids.
Yeah, I think, as we talked to patients and as you think about ourselves too, like what exactly is it that I'm treating at this point? Like, am I treating your non-inflammatory pain with steroids? Do you
Mhm.
have just the steroid dependency? And is there an adrenal insufficiency perspective there?
Yeah.
One thing that I have been doing, more recently is if I have a patient that's been on steroids for a long time and I'm like, I don't know what it is that, that I'm treating here. Or is it that you've just been on them for so long and now your adrenals aren't producing cortisol? Like, can I actually get endocrinology involved? So I think that's a way that we can get some of our other specialties involved and picking up the phone and calling perhaps an endo APP that you might know that can help you. They can be a really good resource, I think, if you have a patient that's been on steroids for like years and they're just like never coming down below 10, having endo get involved to help us kind of try to tease that out to see at that point, is it more just again your adrenal glands and like kind of having some help from there. So that's something that I have been doing more frequently when I just have a person that just will not, they just can't get down. They keep saying like every time I get down, I flare. I'm like, but are you? Because your labs are stable.
Yeah.
Lupus actually appears quiet, and I think it's more that your body just needs these steroids because of how long you've been on it.
Yeah, I've definitely used endocrinology quite a bit too, just in that setting where and it is hard because I think steroids are gonna. I mean, I'm gonna feel good on steroids if I take a bunch of steroids, right? But I think we have to make sure we are explaining, just again the concern about being on the steroids long term, and try our tools, including endocrinology, to try and get them down if we can.
What a great review on why steroid minimization is of value. So let's shift gears a little bit and talk about Doris and why does it feel more unfamiliar than it should? I know for me, being in rheumatology for 19 years, I keep telling my patients we're all growing old together, but even that is a bit foreign to me or was. So for listeners who may not use this term often, can you describe DORIS remission in please practical language and why do you think DORIS remission hasn't fully entered your everyday vocabulary?
Yeah, so I think we obviously all have had the goal of getting our patients in a remission state, right? Where they're not having active disease. And so I think, we just now have some framework around that. And I think what's, beneficial to me with the DORIS remission is doesn't mean like on nothing, right? You're on something. And we know that we need something to control the underlying disease, but it gives us very objective goals like 5 milligrams or less of steroids. They're not flaring. They're not having to go up on their steroid doses. We've got them stable on their hydroxychloroquine and potentially biologic or other DMARDs. And so I think for me, DORIS remission is just really kind of, again, having that framework of really having an objective measure of where I can reach that goal with patients. And then for me as a clinician and in the room with the patient is I'm checking that kind of every time I see that patient, right? Because then I can detect those little nuances, or if a change happens in their blood work or in some of their symptoms, then I can detect it early and then make management changes if I need to.
Do you already align with the underlying goals even if you don't use the label?
Definitely think so. I mean, I think we kind of, this has always been our goal, right? Is to get patients feeling better, right? And living without kind of active disease.
Absolutely. So tell me why remission can be a touchy subject in patient conversations. Like, how do you set patient expectations in remission conversations with these lupus patients?
And I think, remission in the kind of world at large is, in like cancer, right? We think about oncology and how patients are in remission and are no longer on therapy. They're no longer in chemotherapy. And obviously in lupus and in rheumatology, it's remission on therapy. And so we don't have an underlying cure for the underlying disease. And so again, patients, we can get them into a remission, but it's because they're on stable therapy. And I think that's just a good expectation to set up front.
I totally agree. Again, I think, when we talk to patients about remission, it has to be with realistic expectations of what that looks like. And you're so right, because when people hear remission, they think cure. And, then they're like, oh, well, then I don't have to be on any medications. And that is so, so important for our lupus patients to maintain their hydroxychloroquine forever. And I tell people that, like, look, I want you on the least amount of stuff too, other than hydroxychloroquine, which you will be on forever. So, why can remission be a touchy subject in patient conversations? Like, how do you set patient expectations in remission conversations with lupus patients?
Yeah, so I think, in the world at large, remission means cure, right? Like patients are off therapy, like kind of in the oncology world. That's why a lot of people think about that word. But in rheumatology and in lupus, remission is remission on therapy. And so I think it's just setting that expectation. They have to be on therapy. What'll things look like in 10 years from now? We don't know. But as of right now, we're not curing the underlying disease. We're maintaining it and stabilizing it. So they have to stay on therapy.
Really setting those clear expectations so that they understand that I think upfront, like hydroxychloroquine, you will be on hydroxychloroquine forever. Please never stop your hydroxychloroquine unless there's a really, really good reason to do so, right? I mean,
Hmm. Hmm.
I tell people all the time, look, I want you to be on the least amount of medications to control this. But understanding that you likely will need to be on something to control it, because we certainly, we've all seen those patients, sadly, that have stopped their medications and because they feel good, and then their lupus flares with a vengeance, and then they
Hmm.
do need the kidney transplant. I mean, I can think of a person off the top of my head who stopped medications. It was a young woman who stopped her medications and then went into kidney failure. And so,
Yeah.
I really try to set that tone also with patients so that they understand what remission looks like. Like, yeah, we can get you feeling hopefully really good and your labs very stable, but that's going to require you to be on something.
Yeah.
So, how do you translate formal treatment targets into language patients can actually understand?
Yeah, I mean, I think, talking about like those end organ issues that we might see, like, we don't want them to have issues with their kidneys or issues with their cardiovascular system, or, we want their rashes to clear up and we want them to feel better and have less flares. And so, I mean, it's talking them practically with like, how when you don't feel good, we want those things to feel better, right? And so again, it's different for every patient, but I think there's just that overarching, like, everybody's lupus looks a little bit different. And so again, us controlling the disease is really controlling those symptoms and have them not have those symptoms on a regular basis.
Absolutely. So I think this has been such wonderful insight. And as we progress, I would like us to get into making Doris practical. So, how can you and your colleagues take a concept like Doris Remission and make it practical in a busy clinic?
Yeah, that's challenge, right? Because we don't always have a lot of time with our patients and we're always trying to figure out how to maximize our time. But I do think that, the SLEAD I2K, which again is that measurement tool we can use, can be built into EMR systems. I've even copy and pasted it from like an internet browser into the note and just very easily just go through. We're asking the questions anyway. So just kind of plug and chug them into this kind of calculator so we can kind of then now have this more objective information. So I don't think it necessarily takes a lot more time when we're prepared to kind of go over the questions because we're asking the patients these things anyway.
I do the same thing. I actually Google it every single time, and
Yep.
I'm like, "Wait a second, let me Google this," and then I start asking them the questions, right, and then we go through it together, and I'm like, "Wow, this is your SLEDAI score. We don't want it that high. This is what we need to do," and I think it
Hmm.
also then helps the patients set those, realistic expectations that, "Oh, I know I feel better, but I'm obviously not where I need to be." So what does working towards remission really look like in real life?
So I think, not settling for the mediocre. I think I mentioned that earlier, where I mean, we used to go and be like, well, I feel okay. I want patients to know that we don't necessarily have to settle for okay anymore. Like we have tools in our toolbox to get them, down on steroids, in kind of this remission or low disease activity state where they can live their lives and not just feel all the time, right? I think that's just really important for them to understand that we do, and everybody's different, but I do think we have a lot more tools than we used to 10 years ago, right? To get patients where we want them.
So while DORIS remission is an important clinical milestone, it really does feel lofty. So, how do you think about its relevance to long term patient management and outcomes?
I think when we're shooting for DORIS remission and low disease activity, I think, we're being aggressive with, our treatments early on so that we're having less steroid burden over time, because we know the more steroids patients are on over time, the more end organ issues they can have, mortality, all those things kind of go up. And so it just really gives us a goal. But I think, we always are setting expectations for patients. Again, we can't cure this underlying disease, but let's really work to get you in remission. And I think that's something that patients want to work for too. It does seem lofty, but I think again we have a lot of tools now that can really help us get there.
And, having those tools and having the labs, and I don't know about you, but I really do follow the guidelines pretty closely, probably a little more so. Like if I see a patient every 3 months that has, lupus, I'm getting their labs. I'm checking the complements, I'm checking their double stranded, I'm doing a urinalysis every time. Just because I do want to make sure that how they feel also correlates with what their blood work looks like.
Right. I tell patients a lot, we draw labs a lot. We like labs. So we're going to be checking labs and urine and all the things, right?
I know I do the same. I say, "The lab loves me," so, but
Yes.
it's important because that's an added piece, and, when patients leave and they haven't done their blood work, it's like, "Oh my gosh, no, we really do need this,"
Mhm.
and so setting that tone as well, that, how you feel externally is one piece of this, but also I wanna see how things are looking internally as well.
Right.
And, again, that's gonna kinda lead me to my next set of questions for you, which is really talking about patient communication and how to discuss goals without overpromising. So, do you use any other language outside of remission with patients?
But I think, that terminology of, if you can't get to remission, that low disease activity. I mean, it's again, it's very close to remission, but again, just knowing that we want to get patients as good as we can get them, minimizing the steroids that we are using, on the, maximum amount of, medication that can really get them there. And I think, and then practically, like, what does that look like? Less flares. You're not having those days where you just are in bed all day because you don't feel good, or you know, how do your bones look on your bone density, and how do your blood? How does your blood work? I mean, just kind of more practically, like how do they feel, and how are we going to get them to where they're not having as many bad days or having more good days than bad days?
When I think that gets really to this individualized treatment goal, without creating unrealistic expectations. So, how do you do that?
Yeah, I mean, I think you do have to it's a very, open conversation with patients. I think like one of the things that I think is that shared decision making, kind of like you mentioned earlier too, because again, what is their goal in their treatment? Like, do they want to go play golf again? Do they want to, hang out with their grandkids? Do they want to be able to go to work every day and not have to feel like they have to take a nap in the afternoon? I think really understanding what is meaningful to the patient is really important because again we can then really kind of work towards that, right? They have buy-in then because it's they know that what we want, our goal is to get them where they want to be.
I had a lupus patient just yesterday, and she said to me, "Am I gonna be on disability?" And I said, "Gosh, I hope not." I mean, I said that
Mhm.
I want to keep you working. I want you to be doing all of the things that you have been doing. This disease does not need to be your whole life. And I think really talking to them about what does that look like? Is it work? Is it, to your point, is it playing with your grandkids? Is it playing with your own kids? Is it getting them to school? And I think talking to patients, with phrases that work for them so that, because we say DORIS remission, that doesn't mean anything to a patient, right?
Right.
So what phrases do you use when explaining the goals of therapy?
Yeah, I mean, I think we've kind of talked about it some, but just like, just like how can I get you so you're not having flares, you're not taking a bunch of steroids, you're doing those things, kind of think about that, the hack DI or just like things that, they're how they function in life. And those are kind of our goals is to get them so they're feeling as normal as possible on whatever treatment we have them on.
So, when patients start to feel better, oftentimes they're reluctant to change therapy or add in medications. Over the years, and I'm sure you too, there's been many times where we have to kind of convince patients that, no, we do need a little bit more here. So, what are the signs that a patient may need to escalate rather than continue incremental management?
So I think that's where like, kind of the sleep eye comes into play because you're going to be able to detect like those little changes that are happening that maybe, like you mentioned it too, like they may feel one thing on the outside, but what's happening microscopically? Like what's happening in their blood and their, and what are we seeing in their urine and their kidneys? And so I think if we're not checking that sleep eye, we may miss kind of those subtle changes that would be like, we need to do something more, right? We don't want to see protein in your urine. And now we're seeing more protein in your urine. You may not feel it, but because I'm seeing that, I needed to be more aggressive with how I'm treating you. So we don't have end organ, kidney damage and you're on dialysis in a couple years.
So it's really having that objective tool that you can do with your patients every single time, which I think as a practical, tool that people can take home, it's do the sleep I2K every time. Know? Um, Make sure that you are going through that with your patients because of course, some of it's subjective, but also a lot of it's very objective. This is what you do. You have a high double-stranded DNA binding activity. What are your complements? Things like that. I think can be really helpful to where you're saying to your patient, well, I know you say that you're feeling okay, but according to this, I think you're going to need a little bit more. Uh, so, in patients with persistent disease activity, what factors would prompt a reassessment of management?
So, I mean, I think, again, we know that we need to like check just check for different subtle changes. Not every therapy works forever on patients, right? There seems to be times when patients will just kind of, the disease, the medication will just stop working as well. But that's why we're seeing patients regularly, right? Like unlike maybe other specialties, like I'm friends with these patients, right? Like we're seeing them on a regular basis, usually every 3 months, 3 to 4 months with lupus until they're really stable, but at least every 6 months at minimum, right? We're checking labs regularly, we're talking to them and getting feedback. We're not just waiting around until they get a hold of us. We're definitely seeing them on a regular basis. And I think that's what's unique sometimes about how we take care of lupus patients compared to other, specialties. Sometimes we just see them a lot.
One, how can we avoid mistaking partial disease control for full disease control?
Again, I think using those tools where we can just detect those subtle changes, right? And make interventions as earlier than later when we see that something's going the wrong direction.
And to your point, that's why, seeing them on a regular basis, especially like my young patients, like I will tend to make them come back sooner rather than later because I worry about them, especially if you have a young, woman in her 20s, that you just kind of get that spidey sense that something could go wrong here. Like, yeah, you're coming back every 3 months, even
Yep.
if things appear quiet, because it's it's incredible how things can go from quiet to active, and so I think, seeing them regularly and monitoring them and doing the SLEDI and checking their labs in addition to how they feel, I think is really important, and making sure they're taking their medications because, you know, of course, all of my patients never miss their meds, but, if you actually look at data, a lot of people are not taking their therapies as prescribed, and so Having that conversation, looking at their pharmacy record. Are they filling regularly? Some people do hydroxychloroquine levels to make sure that their patients are getting it, getting what they
Yep.
need, so that we do avoid, kind of making the mistake of thinking that they're under better control than perhaps they are.
Hmm. Yep.
So, what factors guide the timing of steroid sparing treatment strategies when disease control remains inadequate?
So I think, you know, the guidelines are helping us now because, again, it's using some of these disease modifying biologics and other therapies earlier, where maybe we would have kept patients on higher dose steroids for longer. And I think that the guidelines are helpful also because it helps with insurance, right? Because we're always dealing with insurances and trying to get things approved. And now that we have guidelines, it just speaks to getting these patients on things earlier. And I think that helps a lot for just kind of that whole process because we know that's one of the hardest parts about the job is we have a way we want to take care of patients, but now we have some guidelines to back it up so that we can support our decisions also with the insurance companies.
Well, I think this has been such an incredible episode, really talking about how we take things that are complicated and try to make it easier for us to understand and be practical when we're talking to our patients.
Hmm.
So, to kind of end this episode, I'd love for you to give us some final takeaways. So, if you wanted our listeners to leave with 2 or 3 practical ideas from this conversation, what would they be?
Yeah, so I kind of thought about this. I think for one, being more diligent about incorporating some objective measures into our daily clinical practice because I know I've been really bad at it for a really long time because I don't have time and I get overwhelmed. And I think again, we can do it fairly quickly now with some of the calculators we have, on the internet or things like that because it's really going to make a big difference on how we treat patients and just notice those subtle nuances. So really trying to incorporate that into your kind of daily practice with these patients. And I think second of all, we've kind of mentioned this is, not settling for okay, right? Like we have tools now and we have guidelines to back it up and we've got data to back up the guidelines to really get patients in this like low disease activity or DORIS remission. And it's just exciting to be able to like have these conversations because again, I think we talked about this at the beginning. With RA, we've been talking about remission and treat to target for a long time. Like talk about remission in lupus patients, like, you know what I mean? Like, that's a shift, right, for us to in our way of thinking. And so I think some of us that have been in rheumatology for longer, like, that's something we need to really have that be our goal. And I think it's kind of a cool thing to talk to patients about too, because again, who doesn't want to be in remission, right? Who doesn't want to have as much of a normal life as possible?
I tell, anyone that will really listen, I think in lupus, we have really shifted. We've been in the biologic era with rheumatoid arthritis really since I started. I mean,
Mhm.
back in 2007. And, we were not obviously there in lupus until more recently, but I think we're there. I talk to patients, we need to be aggressive. We want to control this and we want you to not only feel good and get back to normal, but also have that be reflective in what your labs look like too. So, not being afraid to escalate therapy when you need to, and understand that we have a lot of really good therapies at this point and more to come, when we're talking to our lupus patients, and not being afraid to use them.
Mhm.
Uh, I think, I've certainly seen patients that have come to me for a second opinion, and I'm like, "Oh gosh, you've just been on 10 milligrams of prednisone and hydroxychloroquine, and that's it," or maybe a little methotrexate or some mycophenolate. And it's like, wow, we do have newer therapies. And so I think that'd be the one other thing I would kind of say is don't be afraid to really understand
Mhm.
how these therapies work and not be afraid to use them.
Right. I agree.
Well, this was such a great discussion, Heather. Thank you so much for joining us again and for sharing your perspective. These are the kinds of conversations that really help bring concepts like treat to target and DORIS remission to life in a way that feels practical and usable. And to everyone listening, thank you for spending time with us today. We hope this episode gave you a few takeaways you can bring straight into your practice, whether that's thinking a little differently about treatment goals, steroid use, and how you talk with your patients about what doing well really means in lupus. And doing those SLE-DI 2Ks every time that they come in so that you have an objective way to talk to patients and know when it's time to move on to perhaps other therapies. Be sure to keep an eye out for the rest of this series, where we will continue to dive into key topics in lupus care with a focus on real-world application for advanced practice providers. And a special thank you to AstraZeneca for their continued support of rheumatology APP education and for helping making this series possible. Thank you again for listening to RhAPPcast, and we will see you next time.